and granulomas composed of lymphocytes and epithelioid histocytes, and was suggestive of Hansen's disease borderline tuberculoid. Verified stain showed acid-fast bacilli. Coming to the discussion, Hansen's disease is a chronic infectious granulomatous disease caused by Mycobacterium leprae. It exhibits a wide spectrum of presentation, varying from the tuberculoid to the lepromatous pole, with the immunologically unstable borderline form in between, depending upon the individual's immune status. India accounts for 58.85% of the global leprosy burden. Localized form of multibacillary leprosy is a recognized but an unusual presentation. It was first reported by Leo Yoder et al. In 1985. Till date, only few cases of localized multibacillary leprosy has been reported. The exact pathogenesis of localized multibacillary leprosy is unknown. Job et al. In 1989 reported lesions resembled lepromas that developed following experimental inoculation of Mycobacterium leprae in armadillos. He also suggested the sites commonly affected were those sites prone to trauma, suggesting an inoculation leproma. Also, host immune response play a role. The WHO classification of leprosy for treatment purpose, as per the second WHO study group on chemotherapy of leprosy in 1993, depends on the number of skin lesions only, with paucibacillary leprosy being classified when there are 1 to 5 skin lesions and multibacillary leprosy when there are 6 or more skin lesions. Slit skin smear examination is not mandatory. In our case report, though the patient had only 3 skin lesions, which was consistent with the diagnosis of paucibacillary leprosy as per the WHO classification, slit skin smear examination revealed a bacteriological index of 3+ from the plaque and 1+ from the patch. Thus, WHO classification can result in misdiagnosis of some of the multibacillary leprosy as paucibacillary leprosy, and undertreatment of multibacillary leprosy can result in relapse and disability. To conclude, this case illustrates and emphasizes the importance of slit skin smear examination to help differentiate multibacillary from paucibacillary leprosy so that correct treatment can be commenced. These are my references. Thank you.
Thank you, Dr. Harshpa. Now we request Dr. Lakshmi to present her next paper.
I'll be talking about erythema nodosum leprosum in a 12-year-old boy, a rare case report. Introduction. Leprosy is a chronic infectious disease caused by Mycobacterium leprae, and though leprosy was described almost 3,000 years ago, it is still one of the leading causes of physical disabilities which contribute to intense social stigma, resulting in discrimination of the patient and their families. The prevalence of leprosy in India is 0.68 for 10,000 population, affecting all age groups from infancy to old age, and children below 15 years of age constitute about 10% of the total cases of leprosy. Despite the high prevalence of leprosy in children, the occurrence of both type 1 and type 2 reactions, especially ENL, is rare. ENL has been reported in 0 to 3.1% of all the cases of childhood leprosy. Case report. A 12-year-old boy presented to dermatology outpatients with a complaint of multiple painful lesions over the face and limbs of 20 days duration. Lesions appeared first over the face, followed by upper and lower limbs in crops, and subsided with pigmentation over the next 2 to 3 days. History of fever and myalgia was present. There was no history of hypopigmented lesions, spontaneous blistering or weakness, no history of nasal, testicular, joint or any other systematic complaints. Family history and socio-economic history. Patient's mother was diagnosed with leprosy 6 years back. She belonged to the LL spectrum. She took MDT-MB for 1 year, and within 2 years of completion of treatment, she developed deformity. There were 6 members in the family who lived in 2 rooms, suggestive of overcrowding, and this family belonged to class 4 according to the modified BG Prasad classification. Cutaneous examination. There were multiple erythematous, tender nodules and plaques of varying sizes over the face, upper and lower limbs, back and buttocks. Multiple ill-defined hypopigmented patches arranged asymmetrically over the back. Bilateral ulna, lateral popliteal and posterior tibial nerves were thickened and tender. This is a picture showing multiple erythematous tender nodules over the face and arms. Cutaneous examination of mother. Partial claw hand is present in both the hands. No other skin lesions were present and no nerve thickening was seen. Investigations. Routine blood investigations were within normal limits. Slit skin smear revealed acid-fast bacilli. Here in the picture we can see multiple red acid-fast bacilli. Biopsy showed features of ENL, that is, there is thinning of the epidermis, and under high power we can see foamy macrophages, lymphocytes and neutrophils. This is a picture showing the neutrophils, the foamy cells and the lymphocytes. Histopathology also revealed borderline lepromatous leprosy features, that is, there is thinning of the epidermis and then there are multiple mononuclear cells with few foam cells. Phyte Faraco staining was done, which revealed multiple solidly stained bacilli which were arranged in clumps. Discussion. Living with a patient of leprosy is an important risk factor for the transmission of the disease. If the index case is in the lepromatous spectrum, risk of transmission is 8 to 10 times high, and there is a higher attack rate if the index case is mother. Early detection and treatment is important to halt the spread of the disease, to prevent the occurrence of deformities and to make the patient bacteria free so as to prevent the further transmission of the disease. In conclusion, leprosy in children is considered important because of its potential to cause progressive physical deformity with serious psychological impact on the child and the family. Disabilities are recognizably major factors of stigma associated with leprosy. The presence of familial and extrafamilial contact with leprosy cases in children may be a cause of concern as it implies continuing transmission of the disease. These are my references. Thank you.
Thank you, Dr. Lakshmi. Now I call upon Dr. Nitin Nair to present the paper.
Good afternoon. I'm here to talk about the hoaxes and humbugs in Hansen's disease. A hoax is a humorous or malicious deception, and leprosy is known for its deceptive presentations, which are often misdiagnosed by our colleagues in various other disciplines and sometimes even by the most experienced leprologists. Here we have 4 unusual presentations which may cause diagnostic dilemmas. The first being that of a 7-year-old boy who was admitted in surgery due to trauma on the face 2 weeks ago. He was diagnosed as facial cellulitis and started on antibiotics. A dermatology reference was sought when he did not respond to the same. A detailed history revealed presence of a hypopigmented area prior to trauma and the development of edema and erythema following it. There was also enlargement of the left greater auricular nerve and also sensory impairment over the lesion. On histopathology, it was noticed that there was granulomatous infiltrate, thus concluding it to be a case of BT Hansen's with type 1 lepra reaction. Hemifacial erythematous swelling is a very uncommon manifestation of type 1 reaction or reversal reaction. In this case, trauma was its precipitating factor. Coming to the second case, a 32-year-old male was being treated as a case of foot eczema for over a year. He was unresponsive to topical steroids. And we could see surrounding area of hypopigmentation, which is due to chronic steroid usage. The lesions were non-pruritic, there was loss of sensation and also multiple thickened cutaneous nerves. Histopathology revealed presence of tuberculoid granuloma, diagnosing it to be BT Hansen's disease. Autonomic nerve involvement in leprosy may cause dryness or ichthyosis, which may in turn clinically present with an asteatotic eczema-like picture. A 42-year-old male complained of multiple asymptomatic nodules over the nose for the past 6 months. He was diagnosed to have rhinophyma and was referred to dermatology for further management. We noticed in addition to the nose, he had nodules on the upper lip, malar area and the ear. There was also bilateral symmetrical thickening of the greater auricular and ulnar nerves. On slit skin smear, there was a bacteriological index of 5+, which helped us conclude it to be a case of lepromatous leprosy. In 95% patients of lepromatous leprosy, there's an early involvement of the nose. All granulomatous disorders, such as leprosy and sarcoidosis, should be ruled out in case of nodular infiltration of the nose. Coming to the final case, a 62-year-old male admitted under medicine for features of gastroenteritis, was referred to dermatology for evaluation of erythroderma of 2 years duration. Here is a picture of the back and the abdomen of that patient showing diffuse erythema. We noticed that the patient had bilateral infiltration of the ears and also thickening of almost all peripheral nerves. Histopathology, a positive Phyt staining, and a positive slit skin smear helped us diagnose this case as leprosy. Leprosy is a non-nodular, diffuse type of lepromatous leprosy which may clinically mimic erythroderma due to diffuse infiltration of the skin by histiocytes and leprobacilli. In addition, we also saw two very interesting signs in our patients. The first one being in a case of B.T. Hansen's with type 1 lepra reaction. As you can see, there is an erythematous plaque on the right forearm adjacent to the tattoo of Lord Hanuman. On close observation, you can notice that the infiltrated border of this plaque does not cross the tattoo. Thus, the area of the tattoo is spared. Sparing phenomenon is the absence of lesions of a particular skin disease in an area previously affected by another dermatosis, the mechanism being inhibition of ICAM1 induction in keratinocytes, making it lose its antigen-presenting property. Tattoo sparing phenomenon in leprosy is thought to share the same phenomenon. The second interesting sign was in our case of leprosy. We noticed that the patient had sparing of the axillary folds and also folds of the abdomen, which is known as the deck chair sign. Deck chair sign was thought to be the clinical hallmark of papilloerythroderma of Ophiuchi. Its mechanism in leprosy is thought to be due to increased local temperature along the skin folds, which is unfavorable for the leprobacilli. Though its clinical significance is obscure, we can now say that deck chair sign is not specific to papilloerythroderma of Ophiuchi. To conclude, in the present scenario, with the focus of dermatologists shifting towards cosmetology, and with the resurgence of Hansen's disease, knowledge of the unusual presentations of leprosy will not only help in its early diagnosis and detection, but also in the initiation of adequate treatment without delay. Thank you.
Thank you, Dr. Nitin Nair. Now I request Dr. Monica to present her next paper.
Good afternoon, everyone. I will be presenting on dilemma in management of leprosy. Are we on the right track? 18-year-old female with history of asymptomatic persistent swelling of the upper lip for 6 months. She was treated for angioedema at various hospitals with no improvement. Here we can see a diffuse swelling of both the upper and lower lips. On clinical examination, sensation over the lips and the swelling area was impaired. Feeding superficial cutaneous nerves were not palpable. All peripheral nerves were normal and non-tender. No hypopigmented patches were seen elsewhere. With this, we have come to a differential diagnosis of angioedema and tuberculoid leprosy. We had gone ahead with tuberculoid leprosy for further evaluation since the patient had persistent swelling. We went ahead with slit skin smear, which was negative for AFP. Skin biopsy was also done. Skin biopsy showed unremarkable epidermis, a Grenz zone, and diffuse granulomas present all over the upper, mid, and lower dermis. High-power view showed multiple epithelioid cells and lymphocytic infiltrate. With this, a diagnosis of tuberculoid leprosy was confirmed. Patient was started on PBMDT. 3 months later, patient presented with drooping of the left eyelid and deviation of the angle of the mouth. With this, a diagnosis of left-sided Bell's palsy was made, which could be a type 1 reaction. And then the patient was started on systemic corticosteroids, which were tapered and stopped in 6 months. Bell's palsy recovered completely in about a year's time. Patient was given PBMDT for a year. However, she continued to take the treatment for 6 more months without advice. After completion of a total 18 months of PBMDT, clinically the lip swelling marginally reduced. And to stop MBMDT, a slit skin smear and skin biopsy was performed. Slit skin smear was however negative. Skin biopsy again showed multiple diffuse inflammatory cell infiltrate throughout the dermis, and a high power view showing multiple epithelioid cells and giant cells and also lymphocytes. With this, we have realized that the patient is still not cured of the disease, and MBMDT was decided to be given for 1 year, after completion of which a repeat biopsy and a slit skin smear was done to take the patient off ALT finally. The repeat skin biopsy findings showed inflammatory infiltrate throughout the dermis, a well demarcated giant cell, multiple foamy macrophages, and also lymphocytic infiltrate. Are we looking at a case of drug resistance? So the other treatment modalities that are available to us is RON therapy with monthly rifampicin, ofloxacin, and minocycline therapy, moxifloxacin, clarithromycin, parfloxacin, and rifapentin in several regimens, and several other modalities of giving them through extensive studies. But we are planning to go ahead with parfloxacin, as we have several cases which have improved very well with parfloxacin. This case has been presented to discuss the practical difficulties in treating some cases of leprosy and the options available to clinicians being very debatable. These are my references. Thank you.
Thank you, Dr. Monica. We shall come to the last case reporter, that is by Dr. Shashikiran. I request Dr. Shashikiran to present the paper.
Good afternoon, everyone. I am presenting a case report of familial leprosy, a burden beyond skin and nerves. Coming to introduction, leprosy is a chronic disease caused by Mycobacterium leprae, affects the skin, peripheral nerve system, and certain other tissues, which is infectious in some cases. The rate at which leprosy spreads depends on the susceptibility of the opportunities for contact with leprosy. The family members of the case of leprosy are at risk of contracting the disease. We report the case of 5 patients diagnosed with leprosy in the same family. Coming to case report, a 55-year-old male patient presented to outpatient department with complaints of painful skin lesions all over the body, swelling of face and legs since 3 days. History of joint pains and swelling of foot was present. Clinical examination revealed multiple erythematous tender nodules over the face, upper limb, lower limb, and impaired sensations over the feet with bilateral thickening and tenderness present in the radial nerve, ulnar nerve, and posterior tibial nerves. On respiratory system examination, crepitations were present over the right upper lobe. Complete hemogram showed raised total count. ESR was normal. Sputum for AFB was positive, that is 2+. X-rays showed diffuse fluffy opacities with fibrosis and calcific specks noted in bilateral upper, middle, and left lower zones, showing features of pulmonary tuberculosis. This is a clinical picture of the patient. We can see erythematous tender nodule bilaterally symmetrical over the cheeks of the patient with swelling of the foot. This is a picture showing erythematous tender nodules over the forearm. This is an X-ray picture of the patient where the opacities are predominantly seen on the upper chest lobes, with calcification. Slit skin smear was positive for acid fast bacilli with bacteriological index of 4+. Histopathology showed features of borderline lepromatous leprosy with erythema nodosum leprosum. This is a hyper view of H&E stain of the biopsy sample, where we can see multiple neutrophils along with foamy macrophages present. This is a low power picture of the same biopsy sample where there is epidermal atrophy along with clear gren zone and granulomas and foamy macrophages seen over the dermis. During the consultation of the patient, patient wife was examined and hypopigmented lesions over the upper limb and lower limb were noted. Examination revealed 3 hypopigmented patches over the upper limb, that is the forearm and forearm, and 3 patches were seen over the thighs and legs with decreased sensation. This is a picture showing well-defined hypopigmented patches over the upper limb and lower limb. On further probing, 3 of the 6 children also had similar skin lesions and nerve enlargement consistent with diagnosis of the leprosy. On examination of eldest son, he had two well-defined hypopigmented patches over the forearm, with tender and thickened left ulna. Second son had multiple ill-defined hypopigmented macules over the back with intact sensations. The youngest son had tingling and numbness over the right ring and little finger with no apparent skin lesions, but thickened the right ulna, suggesting pure neurotic leprosy. Skin biopsy of the patient from the biopsy of the lesions from the patients were sent for histopathological examination, and diagnosis of borderline tubercular leprosy was made in patient B and C, and borderline lepromatous in patient D was confirmed. This is a clinical picture of the family. This is the index case, who is 55 years old with the borderline lepromatous leprosy and edema nodosum leprosum. This is a wife with BT Hansen's, and this is a second son with borderline lepromatous leprosy. Coming to discussion, the transmission of leprosy occurs from individual to individual between lepromatous and borderline patient and healthy individuals. Melendez et al. Studied the characteristics of leprosy among couples in Colombian Caribbean coast. Conjugal leprosy accounted for 5.4% of leprosy cases detected during the study period. Of the index cases, 84% were multibacillary lepromatous cases. Of the secondary cases, 61% were possibacillary patients, 42% of them being tubercular. The time between the leprosy being detected in index case and the disease being detected in the secondary patients varied from 5 to 40 years. Lepromatous leprosy in index case was more frequently associated with leprosy in the couple. When the primary case was possibacillary, no multibacillary leprosy occurred in the secondary cases. In our case, index case, that is 55 years old male patient, had borderline lepromatous leprosy, and the wife had borderline tubercular leprosy, and the second son had borderline lepromatous leprosy. The higher risk are associated with living in the same place as untreated patient positive for acid fast bacilli. The route of elimination of the microorganisms are mainly in the upper airways and lesional areas of the skin. The bacilli is highly infectious but presents low pathogenicity and virulence. That is, many people are infected but few get sick. The rate at which leprosy spreads depend on the susceptibility of the individual and the opportunity of the contact with the microorganism. The host innate response is what determines the clinical manifestation of the disease. Contact with infected patients does not always result in transmission of the disease, and different individuals exposed to same infected case develop different clinical forms. Recently, a genetic hypothesis of determination of susceptibility to the infection is being accepted widely. Coming to conclusion, the transmission of leprosy occurs between lepromatous, borderline patients and healthy individuals. High risk are associated with living in the same household as an untreated open case. This Indian family belonged to low socioeconomic class, living in a cozy overcrowded house, is a tailor-made workshop for leprosy. This case report emphasizes the importance of examination of the family members of the newly diagnosed case of leprosy and is being presented for its rarity since 5 of the 8 family members were suffering from leprosy. Thank you.
Thank you, Dr. Shashikaran. We have come to the end of this session. I thank all the postgraduates who took part in this session. I thank the organizing committee members for giving us this opportunity. Thank you, one and all.
Thank you, ma'am. Thank you, sir. I request Dr. Jacinta Martis to hand over the certificate to the judge, Dr. V.P. Shetty. I request Dr. Ganesh Kamath to hand over the certificate to our judge, Dr. V.V. Pai. I request Dr. Jyoti Jayaraman to hand over the certificate to the chairpersons, Dr. Jacinta Martis and Dr. Ganesh Kamath.